All right. All right. Welcome. My name is Sean McKeown, and I'm going to present today on the etiology and treatment of some periodontal diseases. Just a little background on myself. I graduated from the University of Utah and went to dental school at University of the Pacific. Finished there in 2007, and then went to GPR at the VA hospital in Portland, Oregon, where at the time I wasn't particularly interested in specializing, but while I was there, the periodontal residents from Oregon Health and Science University would come over, and I saw what they were doing and became interested, and ended up sticking around for another 3 years and attended the program at OHSU and finished my periodontal residency in 2011. Right now, I work with Jeremy Manwaring at Redwood Periodontics, and I also work 1 day a week at the University of Utah Dental School teaching as part of the perio faculty. So just to review, the major dental diseases of the mouth are caries and periodontal issues. Caries are, the etiology is strep mutans, and periodontal diseases have multiple bacterial etiology, and the host immune response also plays a big role in that as well. So here's a list of some of the more common periodontal diseases, and today I'm going to talk mostly about the first 4 that are listed here. So just to touch on I'll talk more about those in detail, but to touch on the other ones, so abscesses of the periodontium typically are caused by something such as a popcorn husk or something like that working its way into the gingival sulcus and causing an inflammatory reaction there. Periodontitis can be associated with endodontic lesions as well, and developmental or acquired deformities and conditions is what we typically refer to when we're talking about soft tissue defects. But those have been covered already by Dr. Manwaring and Dr. Tunnell, so I'll focus more on some of, like I said, the first 4 diseases that are listed here. So some of the obstacles for identifying the microbial etiology of periodontal disease are, 1, the microbiota is a complex community of microorganisms, and many are difficult or impossible to isolate in a lab. 2, the species that function as pathogens in disease sites may also be present in healthy sites, which complicates things a little bit. The interpretation of the data is greatly influenced by the clinical classification of the disease status, and the physical constraints of the pocket or sulcus make it difficult to obtain a sample. The 5th is that periodontal disease sites within a subject do not appear to be actively progressing at all times. So that can complicate things in terms of identifying which bacteria are causing problems and which pathogens are not there. And to touch a little bit more on that, so in 1984, Sokransky came out with his models of destructive periodontal disease, and he came up with 3. And the asynchronous multiple burst model states that the majority of destructive disease activity takes place within a few years of an individual's life. So in other words, there's a short period of time where the patient has periodontal disease that causes a lot of destruction, and then that stabilizes and stays stable afterwards. The continuous model is probably what we think of most commonly, and that's just a slow and progressive disease. So it continues unless we as clinicians and patients do their part in slowing that disease progression by oral hygiene actions. The random burst model states that disease activity occurs at random at any site. So there's periods of time where the disease is active, and then it stabilizes and then can become active again. You've probably heard about the specific and non-specific plaque hypotheses, and Thilati came up with the non-specific hypothesis. And it maintains that the periodontal disease results from the elaboration of noxious products by the entire plaque flora. So in other words, plaque builds up. The more plaque there is, the more likelihood that there's going to be bone loss and progression of periodontal disease. The specific plaque hypothesis states that there are certain plaque that is pathogenic, and the pathogenicity depends on the presence of increased specific microorganisms. So in other words, it doesn't matter as much how much the quantity of the plaque, but what type of pathogens are within that plaque biofilm. And this also is important because, like I mentioned before, the host immune response to the pathogens plays an important role as well. A little bit on biofilm. It's the composition is microorganisms, organic matrix, and inorganic components like calcium and phosphate. The formation of the pedicle happens within seconds after being cleaned off. And this is thought to be protective in some ways because it creates a barrier. But it also creates an area that allows for initial colonization and secondary colonization of bacteria to adhere to. So over time, we will generally see from a healthy patient going from gram-positive aerobic bacteria moving towards gram-negative anaerobic bacteria. And you can see here the experimental gingivitis that Lowe came up with in '65 talks about how that progresses within a matter of days. Plaque can begin to calcify within 4 to 8 hours. So the modes of attachment of the calculus once that happens are, there's 4 that have been recognized, and this was done in 1953 by Zander. So mechanical locking into surface irregularities. It can lock into cemental resorption defects, secondary cuticle, or penetration of microorganisms into the cement. Some criteria for defining periodontal pathogens are association, elimination, and risk assessment. So association is species should be found more frequently and in higher numbers in cases of infection. Elimination of a species should be accompanied by a parallel remission of the disease. And studies on risk assessment can be used to suggest and or confirm etiological agents in periodontal disease. Virulence factors are influenced by the inherent pathogenic potential of the organism, its habitat, and the host virulence antigens may involve fimbriae, hemagglutinins, proteases, capsule, lipopolysaccharides, etc. And then the host susceptibility. So differences in disease pattern or severity may be due to differences in host susceptibility. However, it's remarkable how few host susceptibility factors have been identified. And we're getting better at that as we're progressing, but it's still a difficult thing to identify. And some of these include defects in PMN function, smoking, nutrition, and systemic diseases such as HIV, diabetes, cancer, and neutropenia. 2 types of transmission that are recognized. So vertical transmission means that it's transmitted from a parent to their offspring, and horizontal is the passage of an organism between individuals outside the parent-offspring relationship, such as husband and wife. The microbiology of periodontal disease I want to touch on a little bit, and like I mentioned before, typically in a healthy periodontium, we'll have more gram-positive facultative rods and aerobic bacteria and cocci, mainly strep and actinomyces species. And there's actually been certain species of bacteria like S. sanguis, which have been proposed to be beneficial or protective to the host. And so not unlike the flora of our gut, there's some bacteria that are protective and some that are detrimental. So in gingivitis, the gram-positive rods and cocci are reduced down to about 44%. And at this point, you're noticing clinically that there's inflammation in the area. And by the time it progresses to periodontitis, where we start seeing bone loss, the gram-positive rods and cocci are decreased to about 10%. And the decrease in gram-positive bacteria is accompanied by increases in the proportions of gram-negative rods, and then in advanced, this progresses. This can also progress into what was previously called localized juvenile periodontitis or generalized aggressive periodontitis. And I should mention here that as I go through this presentation, I'm going to be referring to the 1999 Armitage classification system rather than the new classification system. And there's a couple of reasons I want to do that. One is that I think more people at this point are familiar with that, so it'll be a little bit easier to understand. And two, it's easier, I'm going to talk more about aggressive periodontitis, and it's easier to differentiate in the old system than the new system. But if you're interested in learning about the new system, Dr. Okano did a great presentation that's available on the UDA website as well. So in gingivitis that is associated with dental plaque biofilm, there's about an equal proportion of gram-positive and gram-negative bacteria. About 59% are facultative organisms and 41% are anaerobic. And right here's a list of what the gram-positive and gram-negative species mainly are. And here's a picture of what we would classify as gingivitis. And so you can see that interproximally there's some dental plaque biofilm that's built up there, and that the tissue is really inflamed and bleeds easily on probing there. What there is not at this point is any bone loss. And at that point, that would move to periodontitis. The underlined bacteria here are what we typically associate with gingivitis. The gram-positive bacteria are blue, and the gram-negatives are red in here. And as we go along, we'll have a chart like this for several of the classifications that we move into. Gingivitis can also be associated with pregnancy due to the steroid hormones that accompany pregnancy that are found in the curvicular fluid. And this dramatically increases the level of P intermedia, which uses steroids as growth factors. So I wanted to move in and talk a little bit about some of the desquamative periodontal diseases here. And the reason why I think with everything that's going on these days, there may be an increase in some of these that we're seeing, because they are highly associated with stress, and so we may be coming across these, especially if this pandemic and associated issues continue for a long period of time. But necrotizing ulcerative gingivitis is an inflammation of the gingiva characterized by tissue necrosis of the gingival margin and interdental papillae. Clinically, the condition is often associated with stress, like I mentioned. Symptoms: malodor, pain, and possibly systemic symptoms as well, which could include malodor, pain, and within the body as well. So microbiology is P. intermedia and spirochetes, which are found in all of the necrotizing ulcerative gingivitis cases. So this is what that can look like. And just to touch upon the halitosis that's associated with it, there's a specific name called fetor oris. And it's often strong enough that even after the patient leaves the room, you can still smell that in the area for a period of time. Just like gingivitis compared to periodontitis, with necrotizing ulcerative gingivitis, that changes to necrotizing ulcerative periodontitis once we start seeing bone loss in the area. In terms of history, during World War II was when there was a high association with people that started getting this. And there's common features are stress. So initially it was called trench mouth, and that I think actually occurred during World War I when the soldiers were in the trenches and in severe stress, and also smoking a lot, which is also commonly associated with it. The three illnesses that were recognized were necrotizing ulcerative gingivitis, necrotizing ulcerative periodontitis, and necrotizing stomatitis. So here's a picture of what we would commonly refer to as necrotizing ulcerative periodontitis. And some of the common things that you look for are punched out papillae. And so you can see they're just flattened out and not filling in the embrasure space anymore. Severe inflammation, and again, the fetor oris or halitosis. Here's some radiographs of that, and you can see quite a severe destruction of the bone throughout the mouth. In terms of its relationship to NUG, it's an extension of necrotizing ulcerative gingivitis that leads into the periodontal structures, which then leads to attachment and bone loss. The attachment loss is a consequence of the disease itself. And one thing that can be confusing a little bit is if the patient had previously had periodontal disease, they could still just have necrotizing ulcerative gingivitis that's superimposed over those sites. But if you don't have a history on that patient, then and you took radiographs, you would assume that they have necrotizing ulcerative periodontitis at that point. So the clinical signs and symptoms, according to Carranza, necrosis and ulceration of the papillae or gingival margin, and there's also a pseudomembrane, which I'll talk about in a minute. Painful, bright red, marginal gingiva, which bleeds easily, a halitosis, attachment loss and bone loss, and then, like I mentioned a few slides ago, there's often systemic manifestations such as fever, malaise, and lymphadenopathy. So the membrane covers the necrotic area. It's composed of white blood cells, red blood cells, fibrin, necrotic tissue, bacterial masses, desquaminated epithelial cells, and salivary proteins. And it tears upon removal, exposing the conjunctive tissue underneath it. Some of the differential diagnosis we would go through would be primary herpetic gingivostomatitis, desquamative gingivitis, multiform erythema, pemphigus vulgaris, and we'd also want to refer the patient to a medical doctor to rule out HIV, leukemia, and agranulocytosis. It's often accompanied by people with that are immunosuppressed. So people that are HIV positive, or actually at this point typically associated with AIDS more than HIV positive. So CD4 counts that are lower than 200 are 21 more times likely to have necrotizing ulcerative periodontitis. And this can progress to necrotizing stomatitis, and the bone loss in these cases can be extremely rapid, like it says here, up to 10 millimeters in 3 months. So the non-AIDS type has ulceration and necrosis of the gingival margin, often covered by the pseudomembrane. It may have an erythematous halo, so just a red ring around it, and then PMNs in the ulcerated areas with lymphocytes and plasma cells in the peripheral and deeper areas. And these are what lead to the destruction of the underlying bone, deep crater-like osseous lesions, especially interproximally. Contributing factors, like I mentioned before, so stress increases the cortisone levels, which suppresses the immune system. And so it's often found in soldiers at war, like I mentioned, because of the stress, but also because of poor nutrition playing a role, smoking playing a role, poor oral hygiene playing a role, and then the last factor, which is a role in most types of periodontal disease, I should say, is the host susceptibility. The etiology I mentioned before, but what we mainly find is P. intermedia and spirochetes in most of the necrotizing ulcerative periodontitis cases. And then the host factors include smoking and in terms of host susceptibility, pre-existing gingivitis or periodontitis. The bacterial complexes are mentioned here, and I won't go into much detail, except as we move towards the red complex, the disease progression becomes more severe and more rapid. So we mentioned that the dental plaque biofilm smoking played a role, as did genetics, and then the mental state, stress and coping mechanisms also play a big role. So, you know, if they are in an area such as coming into your office where it's possible to get some psychiatric help, that's not a bad idea to make that referral as well. And there's a little slide that talks a little bit more about that. When we see these patients, so a medical consult's always a good idea, like I mentioned before, to rule out some of the systemic involvement, smoking cessation. And then as a clinician, what we want to do is gentle debridement of the area, put the patient on chlorhexidine and on antibiotics, which the best combination of antibiotics in these cases is going to be amoxicillin and metronidazole. And that can be anywhere from 500 milligrams of amoxicillin and 500 milligrams of metronidazole 3 times a day. I will usually put them on 500 milligrams of amoxicillin and only 250 milligrams of metronidazole, because patients sometimes have a little bit of difficulty tolerating the metronidazole. And one important thing to mention about that is that metronidazole reacts really poorly with alcohol. So if the patient drinks, they need to be aware that they need to stop drinking for the duration of the time that they're on that. It causes severe nausea. After that, reevaluation in 4 to 6 weeks, and that typically will halt that the necrotizing ulcerative periodontitis. Here's a slide that shows, and again, the underlined bacteria are the most common that we find, but this is a slide that shows what we will typically find in a necrotizing ulcerative gingivitis case. And in the next one, you can see P. intermedias in both, but some of the red colonizing bacteria come into play, just like they do with other severe periodontitis cases when it moves to the destruction of bone in the patient. All right, so chronic periodontitis is the loss of connective tissue attachment and bone to the tooth. It's associated with these specific bacteria, and again, they're typically the red colonizing bacteria. And just to talk about that, the way that's broken up is into how early or late the bacteria colonize that. So I think yellow and purple are the early colonizers, and then it moves towards red being the late colonizers in chronic periodontitis. Here's just a clinical picture of chronic periodontitis, a severe case. And once again, here's the bacteria that we would associate with it. And again, here's the same bacteria that we'd find in necrotizing ulcerative periodontitis, and then there's some additional bacteria as well. Here's a comparison of a healthy gingiva, and you can see it again, once just to point out again, so the blue or purple is gram-positive rods and cocci. And so that's in a healthy patient, that's what we would expect to see the majority of the bacteria being. And then as it progresses down to chronic periodontitis, we're going to see a lot more gram-negative rods and cocci. So the disease progression depends on simultaneous occurrence of a number of factors. And these include the susceptibility of the host, both systematically and locally. The local environment has to contain bacterial species which enhance the infection, and an environment conducive to expression of virulent factors. And the pathogens also must achieve sufficient numbers to initiate or cause progression of infection in that particular site or individual. So as we learn more about the bacterial plaque biofilm, we know that the bacteria actually communicate with each other. And so what they'll do is actually start aggregating in an area. And once they reach sufficient numbers to initiate the progression, they'll go on to attack the host. And that's actually called quorum sensing, when they come to the realization that there's enough of them that they can start mounting an attack on the patient. So in what was previously called localized aggressive periodontitis, we see mainly gram-negative anaerobic bacteria. And almost 90% of the flora of the site is associated with Aggregatibacter actinomycetum comitans. And well, typically, when we look at this, the disease affects the permanent first molars and incisors. So if more than an additional 10% of the teeth, other than the first molars and incisors, are affected, then we'll consider that generalized aggressive periodontitis. It's really frequently symmetrical, so if you see it on number 3, you're going to see it on number 14 as well. And sometimes there's very little gingival inflammation, and it's oftentimes refractory to mechanical therapy. So this is a patient I saw a number of years ago. She was a 14-year-old that came into the clinic, and she wasn't in any discomfort at all, but her mom and her grandma were both in dentures by the time they were in their early 20s. And she had seen a dentist, and he had recognized that there was some periodontitis going on, and they didn't want the same thing to happen to her. So they send her over, and healthy patient has regularly been seen by a dentist, and I saw her in 2008, and at that point there were several permanent first molars and incisors that were affected, but in this case I'm going to show some of the defects that we found between 25 and 26 and 29 and 30. I'm going to skip through some of this, but she actually took pretty good care of her teeth. She flosses daily, used an electric toothbrush, and for the most part did pretty well with her oral hygiene at home. Vital signs were all within the normal limits. No significant extra oral findings. TMJ was asymptomatic, and other than some minor past restorative treatments, everything looked pretty healthy in her mouth. So just evaluating her overall gingival characteristics, coral pink scalloped papillae, which we associate with healthy tissue, and just those couple of areas that I mentioned. So if you look at the mesial of number 30, and you can see actually the mesial of number 3 in the bite wings as well, you can see some bone loss that's occurred in the area. But probing depths other than those areas, everything looked healthy and no problems. Also, the distal of number 25 had an angular defect with a 7mm probing depth. When we evaluate osseous defects, the more bony walls remaining, the easier it is to regenerate the bony tissue there. And so a one-wall defect can also be called an angular defect frequently, which is what we are looking at right here. So there's just a single wall of bone against that tooth, whereas a three-wall defect has 3 bony walls remaining. Ocean Beam classified these as shallow, medium, and deep, depending on how many millimeters they were. And here's just a picture of the right buccal area. Everything looks healthy there. Slight inflammation are around number 30, but nothing real significant there. We do see some significant inflammation on the distal of number 25, though. And so we diagnosed her with plaque biofilm-induced gingivitis and localized severe aggressive periodontitis of 3, 25, and 30. So aggressive periodontitis, some of the signs of it, typically they're otherwise clinically healthy. The attachment loss and bone destruction is very rapid. There's familial aggregation, so a strong genetic component to it. And the disease sites usually are infected with Aggregatibacter actinomycetum comitans. And that's important because that changes the way we treat this compared to just the standard scaling and replaning and re-eval, which we'll do with the chronic periodontitis patient. And the reason why is that the AA actually embeds itself into the connective tissue. And there's some bacteria that do that in chronic periodontitis as well, but not nearly as significantly as AA does. And so what that means is even if you scale or root plane the patient, the AA remains in the tissue. And so in order to compensate for that, we will typically prescribe antibiotics for both localized aggressive and generalized aggressive cases. So localized aggressive periodontitis, there's usually comes on around puberty. It's a pretty low prevalence, 0.2% of the population. And like I mentioned before, at least 2 permanent first molars and incisors are affected with no more than 2 teeth other than the first molars or incisors. The one other thing that's important to point out is the amount of plaque or calculus doesn't necessarily correspond with the rate of destruction that you're looking at, both radiographically and clinically. And that's the same for generalized aggressive periodontitis as well. As I mentioned before, AA, it's isolated in 97% of the localized aggressive cases. It's absent from healthy sites of effective individuals, despite large numbers in the diseased sites, and it can be found within the connective tissue. And they've actually, I don't think this would pass any board at this point, but they in the past tried to do studies where they would take cultures from the infected sites of an individual and try and transplant it to the healthy sites of the same individual, and nothing progressed in those healthy sites. So it's non-motile, so it doesn't move on its own, and the way it actually travels around is by piggybacking off of another bacteria called Capnocytophagus. So you'll also find that in most of the aggressive cases as well. And I'll skip through this a little bit, but the endotoxins, the main virulence factor with leukotoxin and collagenase also playing a role. So as I mentioned, that study where they weren't able to transfer it to the healthy sites, there's some theories behind that, and one is that since it's the initial teeth that erupt in the mouth that are affected typically, there's a strong immune response to that, and so one of the theories behind why it doesn't spread to the additional teeth is that it initially appears when the permanent teeth erupt, and then the patient has a really strong immune response, and that keeps the bacteria at bay from moving on and affecting the additional teeth there. So when we treat these patients, I mentioned already that we treat them in conjunction with the scaling and replaning. We also typically will put them on antibiotics. And that will usually be either doxycycline or a combination of amoxicillin and metronidazole. And there's been a lot of studies on this as well. The amoxicillin and metronidazole typically has been shown to be the most effective combination of antibiotics, but it's also, as I mentioned, harder on the patient system. And so doxycycline is a good alternative to that and doesn't seem to affect them systemically as much. After this, so I'll put them on the antibiotics just to go through this a little bit in more detail. And I'll have them start it the day before we start the scaling and replaning. And in the aggressive cases, I will try and get all of the scaling and replaning done within a short amount of time as possible and leave them on the antibiotics for about a week. And then we'll have them come back for the reevaluation in 4 to 6 weeks and decide at that point what direction to go. So here's the probing depths at the reevaluation. So still have a 6 millimeter probing depth and a 5 millimeter on the mesial of number 30. And still on number 25 have a 6 and a 7. So didn't resolve much in this case, which but what we do see when I flip to the next slide is that the inflammation is cleared up completely. So hopefully we have at this point eradicated the bacteria and stopped the progression of the disease. So we decided at this point to do some guided tissue regeneration. And so when we do this, like I mentioned before, it's a lot more successful the more bony walls that are remaining to the patient. So when we look at number 30, we're going to expect to have a really good result. Whereas on number 25, there's just nothing to really pack bone against and contain it and stabilize it. So in that case, we'll use another method here. But here's just a systemic review that shows that GTR is more effective than open flap debridement in gain of attachment and probing depth reduction. So I put this slide on here just because this is what we ended up using on number 25, because again, the bone graft just wasn't going to be stable or stay in place. So M to gain is enamel matrix proteins that are isolated from the developing tooth buds of pigs. And it comes with what's called Pref gel, which is just 24% EDTA. And it's non-acidic, it's neutral pH, but it acts almost similarly to acid etch would. So it takes off the smear layer after you replane the tooth. And then the enamel matrix proteins go in and basically stimulate the body to send in reparative cells to the area. So, so just made some initial incisions here and then reflected the tissue. And again, you can see that on number 30, we have a buccal wall, a mesial wall, and a lingual wall there. So this is going to be a really straightforward regeneration case. So we're going to debride the defect and replane it really well, and then put some bone grafting material in there. protective membrane. In this case, we use BioGuide, but there are several types that all work really well. And these are, doesn't need to be, but typically we'll use resorbable membranes in these cases. And then I guess I didn't show it, but so on number 25, after we debrided that, we used only the Pref gel and the Emdogain, and then just closed it up. So no bone, no membrane in that area. Sutured it with fluorochromic gut. And here's a 1-week post-op, a 3-month post-op, and then here's what the radiographs look like at 3 months out. And here is after 1 year. So everything clinically looks very healthy. And here's the 1 year post-op on both those sites. And here's a comparison here. So again, this is really predictable. We're going to expect that to happen anytime you have a 3-wall defect. We're going to get really good bone regeneration. But this case is actually interesting with the angular defect, just using that Emdogain. And you can see, so here's the initial defect. What's interesting to me is you can actually see the periodontal ligament in place as the bone migrates more and more coronally. And obviously my last follow-up was in 2010, but my guess is if we took a picture of her today, you wouldn't even be able to tell that there was ever a defect there. I think it would have continued to heal and migrate coronally there. Here's a quick aggressive case that I just wanted to run through. And this was a 36-year-old male. So typically with aggressive periodontitis, it's going to be in a younger individual, so in their 30s or before, but not always. But that's one thing that we'll look for, is if there's a lot of destruction of bone in a younger patient. Here's just some of the initial presentations and some radiographs here. So here's the mandibular right sextant. You can see that the probing depths are fairly significant, 7s and 8s of probing depths and clinical attachment loss. There's actually up to 10 millimeters of clinical attachment loss on 29 there. There's a full mouth series that we took. And so you can just see how much bone loss there is for, and the other thing that jumps out is that when you're looking at what we would interpret to be radiographic calculus, there's just not a whole lot of it in place there. So there's a ton of destruction of bone with relatively minor amounts of calculus that's built up there. And again, we're using the 1999 workshop from Armitage, and diagnosed this patient with generalized severe aggressive periodontitis with secondary occlusal trauma. And I put that in there because a lot of times as the bone deteriorates, the teeth will shift and they'll go into malocclusion, where they're really hitting traumatically against the opposing occlusion. And so part of the treatment is also going to be adjusting that. And I'll skip through this pretty quickly, but because I think we talked about most of these. But again, the amounts of microbial deposits are inconsistent with the severity of periodontal tissue destruction. So they can have pretty good oral hygiene and still be having really quickly progressing periodontitis. Again, typically it will start with patients that are under 30 years of age, but they may be older, and you know, oftentimes, such as the case with this patient, it probably started when they were under 30 years of age, but by the time we saw him, he was, I think, 36, I think is what that slide said before. P. gingivalis and T. forsythia are frequently detected in these cases. And so to talk briefly about the therapeutic goals, it's to eliminate the microbial etiology and contributing risk factors for periodontitis. arrest the progression of the disease, and preserve the dentition in comfort, function, and appropriate aesthetics. And then once we've done that, prevent the recurrence of it, and then in areas that we can, regenerate the attachment apparatus. So considerations, oral hygiene instruction with any periodontitis patient is going to be really important, but especially in aggressive cases. Reinforcement and evaluation of the plaque biofilm control. So brushing, flossing is going to be really critical. We're going to start just like we would with chronic periodontitis. We're going to start with scaling and root planing. Control other local factors like malocclusion and anything else that may contribute, such as diastomata or other things that could be impacting the disease as well. So we'll refer to a general dentist to get some restorative things fixed if we need to. And then periodontal surgery and maintenance. I've highlighted how important the patient compliance is, but really it doesn't matter what as a clinician we do if they're not going to put in the effort to really work on it at home themselves. The other thing, since there is such a strong genetic component, it's worth mentioning to the patient that additional family members should be evaluated as well. So when we're assessing the outcomes, we're going to include significant, what we want to see is a reduction in the clinical signs of inflammation, or a reduction of the probing depths, stabilization of the attachment, and radiographic evidence of resolution of osseous lesions and progress towards stability. So phase 1, oral hygiene instruction. Again, with any aggressive case, we're going to put them on either doxycycline 100 milligrams twice a day, or that combination of metronidazole and amoxicillin. And I've talked enough about this, why we in these cases want to use the antibiotics, but there's a little bit more information on them. And then at the re-eval, a couple of months later, probing depths have improved actually quite significantly. And the tissue also looks a lot healthier here. At this point, we're going to keep any generalized aggressive case on a 3-month maintenance. And the reason why we want to do it every 3 months is that even in the absence of good oral hygiene at home, if we're seeing a patient every 3 months for maintenance, there is some evidence that we should be able to maintain the stability of the disease. Here's just some radiographs from the reevaluation there. And then at this point, we went in to, again, do some regeneration of those osseous defects. And so basically laid some full thickness flaps in the area, debrided and root-planed, debrided the defects really well and root-planed the teeth. And then put some bone grafting material in there, along with some so in this case, GEM21, which is growth factors that, again, somewhat similarly to MDGAIN, stimulate the patient's body to send in cells that will repair the area. And the bone's in place. And then we, again, put a resorbable membrane over that and then suture it. And there's the the day of surgery there, sutured in place. And here's the 1 week post-op. Everything looks like it's healing really well. And after 1 month, it still looks like everything is healing. We'll typically, in these cases, get a combination of regeneration with a little bit, we'll do osteosurgery at the same time, which drops down it reduces the probing depth, but also increases the recession in the area a little bit. And the reason, so it's considered a compromised surgery when that happens, but it creates an area that's a lot easier for the patient to keep clean. So in areas that are amenable to regenerating the tissue, we'll always do that. In the areas that aren't, we'll just reshape the bone so that that tissue sits down a little bit lower and creates an area that's easy for the patient to maintain at home. All right, so almost done here, but I wanted to go back into, and this is getting out of the aggressive cases, but to talk a little bit more about the etiology. So Koch's postulates states that the causative agent must, 1, be routinely isolated from diseased individuals, 2, be grown in a pure culture in the lab, 3, produce a similar disease in experimental animals, and 4, be recovered from infected experimental animals. And this criteria remains the basis for elucidating infectious agents. It's used in caries research, for instance, but it's hard to apply it to periodontal disease because of the inability to culture all the organisms that are associated with the disease, difficulties in defining and culturing sites of active disease, and the lack of good animal models that we have for periodontal disease. Considering microorganisms as a periodontal pathogen and using those postulates, the only ones that are strongly associated with periodontitis, although we know there are several others that play roles, but the only ones, according to those, that we have a strong correlation are AA, P. gingivalis, and T. forsythia. I talked about the role of AA in aggressive periodontitis, but it's also sometimes found in chronic periodontitis as well. But we highlight it during aggressive because it's almost always found in those cases. And again, collagenase, leukotoxin, and endotoxin are some of the main virulence factors for AA. Some of the role of P. gingivalis, it's increased in periodontitis lesions. It's eliminated when therapy is successful and the area becomes healthy. The host response has increased systemic and local antibody levels to this in periodontitis. And in animal studies, it's been found in both monkeys and the dog studies that we've done. Bacterial adherence is an essential step for the invasion. So the species that colonize the crevice must attach to available surfaces to avoid displacement by the gingival crevicular fluid. So the tooth, root, tissues, and pre-existing plaque mass are surfaces that are available for these. And P. gingivalis has the ability of attaching to other bacteria, epithelial cells, fibrinogen, and fibronectin as well. So the presence of bacteria in periodontal tissues has been demonstrated in all of gingivitis, chronic periodontitis, and aggressive periodontitis. And the bacteria, as I mentioned, especially AA, may enter the host tissues through ulcerations in the epithelium and then get into the connective tissue at that point. P. gingivalis, AA, and T. denticula can invade tissue by direct penetration through the connective tissue cells. And P. gingivalis has the ability to degrade the interepithelial proteins, thus potentially invading connective tissue by a paracellular route as well. And the significance of this isn't exactly clear, but bacteria associated with invasion has been associated with the disease. And the burst of activity observed during periodontitis may be associated with bacterial invasion of the host tissues there. And I think that will do it. If you have any questions or comments, feel free to contact me at any point. I can be found at Redwood Periodontics, and the number is easy to find online. So thank you for letting me present, and take care.